to our NCLEX RN review. So this week has gone by so fast, and I'm hoping that you have gained a handful of learnings from these sessions. And if you don't mind, I would really like you to drop your comments and tell us your questions so we can get back to you in the next sessions. And for those who just joined us, we're on the 9th day of the 90-day free NCLEX review classes, which we schedule daily at 12 p.m. Eastern Standard Time. And we are covering all nursing subjects and also rationalization of 2000 NCLEX questions. For today, I'll talk about the nursing care and management for an adult patient with benign prostatic hypertrophy, and we'll have some Q&A right after. But before we go into our topic, I really want you to check out our course that we are offering in our website, and that is at www.stancoastnclexcoaching.com. And we are also want to make sure that you are sharing this YouTube channel, especially with the live classes that we're offering. And this is going to be at least within 90 days duration. And we want to invite you and your friends to like and subscribe. Make sure that you also make comments down below so we can answer your questions. And so again, the schedule for the classes will be every 12 p.m. Eastern Standard Time, and this will be available after the streaming. And also we are gonna offer again the course with the NCLEX course that we're offering through the website. We're offering about the different on-demand videos and also ebook practice tests, and also 200 plus of NGN test questions. And these are available 24/7, and the discount is still on. That is 70% discount of the original price. And so we want to make sure that you grab this opportunity so you can get ahead and pass your NCLEX soon. Now, we'll start with a topic right now about the prostate gland. So we haven't really talked about the anatomy and physiology about the prostate gland during the first session. I really intended to do this as a separate session so we can focus into the anatomy and physiology of this organ. Now, just a quick review here that the prostate gland is a small single donut-shaped gland that is very comparable to a golf ball. Okay, that's quite small. So from side to side, it measures about 1.6 inches or 4 centimeters. And from top to bottom, it measures about 3 centimeters or 1.2 inches. And from anterior to posterior, it measures about 2 centimeters. So not quite a huge organ. Now, it is located inferior to the urinary bladder, and it surrounds the prostatic urethra. And it's actually going to function into helping with the secretion, especially with the production of the prostatic fluid, because the prostate gland can secrete a slightly alkaline fluid that can constitute about 20 to 30% of the volume of the semen. And this fluid will help nourish and also transport sperm and its alkalinity. This can help to neutralize the acidic environment of the vagina, and therefore it can also protect the sperm and enhancing their motility. Now, another function is about enzyme secretion. So the prostate gland can produce several enzymes, and this include the prostate-specific antigen, or known as the PSA, and also the prostatic acid phosphatase. So going back into the concept of the PSA, it helps liquefy the semen following the ejaculation, and it can help the sperm to swim freely. And on the other hand, the PAP, or the prostatic acid phosphatase, plays a role in the semen liquefaction, and also it's linked to so many various sperm function and also its survival. Now, it can also protect and nourish the sperm because it contains various substances that will help it, such as the citric acid, zinc, also magnesium, and of course it can help the vitality and function of the sperm. Now, as far as the regulation of the seminal fluid volume, the prostate can also help to control the volume and the consistency of the seminal fluid, and it is optimal for sperm transport and also survival. Now, talking about another function here is the muscle contraction, wherein the prostate gland contains smooth muscle fibers that can actually help expel the semen during the ejaculation. And the contractions of these muscles can also contribute to the force and the direction of the semen emission. Now, we are not going to forget that it has also a function as an antibacterial effect, because the secretions that it is secreting actually has some antibacterial properties, which is going to protect the urinary and reproductive tracts from any infections. And also with its function with hormonal influence, because it can respond to the androgens, primarily the testosterone, which can regulate its growth and the function. So the hormonal balance is also essential for maintaining the prostate's health. Now, part of that would be its role in fertility. It can play a critical role in the male fertility by ensuring that the seminal fluid is conducive to sperm survival and also its function. And of course, to facilitate the successful fertilization. Now, what the focus here today is on the prostate itself. And of course, there will be some abnormality. There probably is going to be proliferation or abnormal growth of the cell, especially in the prostate gland. And again, this can lead to that problem, which is the benign prostatic hyperplasia or hypertrophy, which is basically a gradual enlargement of the prostate gland. And we're talking about an increase in both the size and also the number of the normal tissue cells. Again, that's the size and also the number of the tissue cells. Now, when this overgrowth of the prostate gland occur, then this will now compress the urethra, and it can also lead to, let's say, partial, or it could end up as a full blockage. And so the person here, especially the elderly male, will have trouble in passing their urine. And this can do a lot of complications that we'll be talking later on. And most often, this is going to affect men over the age of 50. Okay, so you will expect that probably when you're going to be exposed in the medical surgical setting, in your nursing career, you're going to deal with a lot of the elderly population, and most of them will probably have trouble in their prostate gland, such as the BPH. Now let's talk about the complications here. Now I'm showing you the picture here about that weird overgrowth of the prostate gland, which is basically located surrounding the neck of the urinary bladder. And so when it's enlarged, when there is a overgrowth of the tissue, it can choke the passage, which is basically the urethra at the juncture of the urinary bladder. And so there will be difficulty in passing the urine. And again, it can lead to complications. Now, as far as the incidence, about 14 million men in the US and about 30 million men are affected by this condition. And also, the contributing factors that we have are the following. It could be that there's higher levels of testosterone, or could be an increase in the 5-alpha reductase activity, or could be high androgen receptor expression, and maybe an elevation of the growth factor activity. And here we go. It can lead to a whole lot of complications, such as the urinary retention, could be kidney insufficiency, could be urinary tract infections, gross hematuria. There could be some bladder stones as well because of stagnation of the urine, and kidney failure or uremia, which can be kind of rare in the current practice, but some patients could reach that point. Okay. Now, we talked about the BPH partly when we discussed about the acute renal failure, and so this is going to be one of those post-renal predisposing factors. okay, especially that there is a problem in the outflow of the urine. So it can lead into backflowing of the urine from the lower urinary tract into the upper portion of the kidney, and it will mess up the structure of those special, the glomerulus, the nephron itself will be destroyed. Now we're going to talk about the assessment findings. This is going to be easy, actually. This is very easy. The more of the complexities here will be more on the nursing care. It's quite lengthy, but as far as the understanding with the assessment, it's so easy to recall. And so when the patient is going to complain about this problem, most of the time their chief complaint here is the reduction of the urinary stream size and also the strength. And this is the earliest indication that they have the BPH, okay? Reduction in the urinary stream. It's kind of weak. Even though if they start to kind of bear down a little bit, they'll probably just gonna end up farting, but no urine stream. And you probably would hear this when you are assisting the patient into the bathroom when they're having a hard time urinating. And also, there's gonna be increased urgency and frequency of urination. It's because that they're not able to empty fully their bladder, and they have that urge because the bladder is still there. It's distended. And I don't know if you still recall this back in your BSN program, back in nursing school, that you will feel the urge to urinate once the urinary bladder accommodates at least 240 mLs. Yeah, that's not a lot. That's just like a small cup of water. Yeah, it will be enough for you to cause that urge to urinate. But when you're going to try to hold, and because there's no available bathroom, and so that sensation will dissipate for maybe a few minutes or hours, and then the concentration, or let's say the collection of the urine in the bladder, will increase up until it probably grows into 1 liter or 1.5. Yeah, I had an experience with an older lady that she wasn't even able to pass urine because of the, I'm not quite sure what happened. Maybe she was taking something else, but yeah, when we did cath her, she emptied like almost 2 liters. We were shocked, and we didn't know how long she was having that urine because she was a new admission. And so, yeah, that was even a woman. And I can't imagine if this is really happening to an older man with a BPH. Probably they can accommodate more than that. It's just appalling. Now, we're going to talk about some nighttime urination or nocturia. This is going to be a common thing, and this will really bother the periods of rest in our patient. Some of these patients will end up falling in the middle of the night once they go to the bathroom because they could do this back and forth all throughout the night. And probably they get so tired, they'll just end up wearing a TENS or diaper. Trust me, this is reality. And we're also gonna hear some complaints about difficulty in starting, or let's say that is what we call as hesitancy, or at least to maintain a urinary stream. That is also that complaint. Now, there is also sensation of incomplete bladder emptying. Yeah, have you experienced this? That even that you just went to the bathroom, you thought that you already done your job in urinating, but you still feel like something is still in there, that you have not completely emptied your bladder. It is an uncomfortable feeling. Now, there's also going to be dribbling after you or after the patient had urinated, because this is what we call as an overflow incontinence, okay? And this is a symptom towards the later stage of the BPH. So please take note of this. Dribbling after urination, and this is what we call as overflow incontinence. Now, another is the urinary retention and bladder enlargement. Yes, because of the prolonged retention of the urine in the bladder, it really had to accommodate that volume inside, and yeah, it will cause some weakening of the muscles of the bladder as well. Now we're gonna see this in their laboratory result. There will be presence of blood. Maybe it could be gross hematuria or it could be a microscopic hematuria. It could probably some infection going on in the urinary tract. And because of the urinary stagnation, there will be some urinary tract infections that will accompany with this problem. And this is a common issue in the older population, especially the men. Okay. This will really affect their ADLs. They can get confused once they develop urinary tract infection. They would not want to eat. They'll just sleep all day. And yeah, we'll get confused. Why is this patient not participating in their daily activities anymore? Not even taking a bath. Yeah, this is something that has happened to many of patients back in the nursing home or the assisted living facility. And also there's going to be painful urination and bladder discomfort. And this is also associated with the urinary tract infection. Now we'll talk about the different diagnostic exams, and we'll go through starting with the physical examination, of course, with the digital rectal exam. We call it as the DRE, and this is going to be done primarily by the provider, and very crucial in really evaluating the men with the suspected BPH, because with that kind of procedure, the provider will be able to assess the prostate size and shape, and also to check for any kind of nodules, and they can also identify areas indicative of maybe some malignancy. Although BPH really is not equivalent to malignancy, but with the enlargement, some of these cases probably will be malignant kind. Now, as far as some laboratory studies, we have the simplest lab study, which is the urinalysis. This is going to be included as part of the treatment. This is to check for the blood, hematuria, leukocytes, if there's any infection, for bacteria as well, if there's any protein leak into the urine, or probably glucose. And this is going to be done through the dipstick method and could be done through a centrifuge sediment evaluation. Now, another testing here is doing the urine culture. So we basically have to carefully collect the urine sample midstream, making sure that the sample is collected properly, that it's not contaminated, because usually the lab scientists will be able to tell that the urine specimen is contaminated by, let's say, the skin or whatever normal flora, if they can identify those bacteria that are normally found in the skin. So if there is poor preparation of the perineum, if they are not following your instruction, if the patient is not following the instruction of cleansing first their meatus before the collection, usually the lab scientists will know that this is not a good sample because it's contaminated by the surrounding skin or the environment that is contaminated. And so once you do this correctly, this urine culture can actually rule out infectious causes because of, yeah, it can readily identify the microorganisms, and usually it's the E. coli, the most abundant microorganism that can migrate from the anal area or rectal area into the urethra. Okay, even males can get that kind of infection. Now, we're also going to talk about the prostate-specific antigen, or the PSA. Even though that the BPH does not really cause prostate cancer, I just want to emphasize this, that BPH does not cause prostate cancer. But men that are at risk for BPH should also be screened for the prostate cancer because of the close affinity between the two. There will be an elevation of the PSA in both cases, the prostate cancer and also the BPH. So if there is such elevation of the PSA, it's just not specific, again, to the BPH. It can also relate to possible malignancy of the prostate. And when there is elevation of the PSA, this is really attributed to maybe an enlargement, because an enlarged prostate itself, or if there is widespread proliferation of the tissue, this can also produce more PSA. And that is why it's very important that the doctor will have to order some more testing to investigate if this is just a BPH issue or maybe if there's a prostate cancer problem going on. Now, another is the other testing such as electrolytes, could be the blood urea nitrogen or could be the creatinine. And these screening tests can also be used for those patients with CKD. If the patient has some associated medical history with CKD, and so the doctor will have to check onto the creatinine, BUN, and the other electrolytes. And also, the creatinine is something that is not initially ordered by the physician because the BPH is usually going to be screened in a what do you call it, a step-by-step manner. And so if they're only suspecting a lower urinary tract infection, and so creatinine usually will not be included at this point. But however, if there is association with other issues, let's say chronic diabetes or maybe hypertension, then the creatinine testing will be included. Now, we are also going to talk about the ultrasonography, the regular abdominal ultrasound, and this is going to be ordered to determine the bladder size and also to assess the degree of the hydronephrosis for those patients that might have developed the backflow of the urine into the pelvis of the kidney, or at least the edema in the kidney. And so again, this is going to be an effective means of detecting that. And also, again, the ultrasonography is not generally used as an initial diagnostic test, especially for an uncomplicated lower urinary tract infection. Okay. Now, another thing that we're going to talk about is the cystoscopy, which is also an endoscopy of the lower urinary tract. And this is going to be indicated for those patients that may have some treatment. Let's say, for example, they might have a suspected foreign body, or let's say they might have some issue with sexually transmitted diseases, or maybe if they have a history of prolonged catheterization, or if they have some kind of procedure, an invasive procedure like biopsy or stone removal or a resection of the tumor, then cystoscopy can be indicated as well. All right. Now, if there is also malignancy, then cystoscopy is really going to help out in helping to establish the diagnosis. And same thing with STIs, prolonged catheterization, and history of trauma. Now, other than the diagnostic test or imaging studies or the laboratory, we're also going to talk about the IPSS AUA-SI, and this stands for the International Prostate Symptom Score, and also the American Urological Association Symptom Index. And so this is going to be the standard that will be used by the medical provider, along with specific quality questions in order that they can measure the severity. They can quantify the severity of the manifestations in this patient that possibly could have a BPH. And so the scoring method can also quantify about the severity of their symptoms according to how the patient is able to empty their bladder, if there's any difficulty, like maybe some frequency or urgency, or some maybe weak urinary stream, or could be the use of straining in order to just pass the urine. And so this will be scored accordingly. And if there's also presence of nocturia. All right, so don't forget about the IPSS AUA-SI. Now we're also going to talk about the flow rate, which is a simple testing that will be done to assess the initial symptoms and treatment response. And the PVR, urine volume, is something that even us nurses can do. And what we can do here is to get that bladder scan, which is basically a bedside ultrasound test that is pretty much available in the nursing unit. But I remember way back in 2004 when I was a brand new med-surg nurse, that the use of the bladder scanner around that year was quite new to the nurses, that it still required the doctor's order. Yeah, could remember that we cannot really use it without a doctor's order, but now it's part of the protocol in some nursing units, but it still varies from one institution to the next. Some of the institutions still require order for the use of the bladder scanner, but most of the hospital can allow the nurses to do it in order to do a spot check into the patient's bladder to see if they are retaining urine. And so this is basically I forgot to put in a picture, but yeah, I'll probably show that to you in the next discussion. But this is really gonna measure how much the patient is retaining in the bladder after they attempted to urinate. So for example, maybe the patient was assisted to use the urinal or use the bathroom in a sitting position. Yes, even the males who are really trying hard to urinate sometimes would sit down to allow them to relax. Yeah, and sometimes it would take like 30 minutes or 40 minutes just to pass that small amount of urine. You have to be patient because, yeah, it's their reality of the disorder. I mean, they will have a delayed voiding time, and you just have to be patient with them, especially nursing aides who are so busy with dealing with other patients. Now, the PVR is, again, going to be a specific tool in measuring the retained amount of urine in the bladder. And if it's not available in the institution, then probably in the not so high-tech hospital, maybe they are using the INO catheter, a temporary insertion of a catheter, to just empty the bladder, and then they will take out that catheter after it's emptied. But that's a whole lot of unnecessary catheterization, I would say. And there's going to be a whole lot of trauma that can be involved, that will be involved in that case if we have to do a whole lot of catheterization just to do that kind of residual checking. And so the PVR really, with the use of the ultrasound, would be much safer. Now, we're also going to talk about the management here, and hang tight there because we're going to talk about the pharmacologic management. And so we'll start with the first classification, which is the alpha adrenergic receptor blockers. And this is actually considered as one of the antihypertensive medications. And so you probably recognize these drugs, but these are specific medications to treat the BPH. All right, so you'll see here tamsulosin, terazosin, and doxazosin. So look at the suffixes here: zosin, zosin, losin, tamsulosin, and the brand name for the tamsulosin is Flomax. How brilliant that when they made that brand name, Flomax, to allow a good stream of urine, Flomax. And the action of this medication, basically, or this classification, is to allow the relaxation of the smooth muscles in the prostate gland. Remember, I talked about the layer of that muscle tissue in the prostate. And so it has that ability to contract, and it also has the ability to relax. So at this time, when the patient's prostate gland is somewhat stiff, it will allow it to relax, and it will now ease the flow of the urine into the lower end of the urinary tract. All right. Now, please take note, guys, that since this is an alpha adrenergic blocker, we'll just call this alpha blocker. We'll just get rid of the adrenergic because it makes the name a little bit longer. Yeah, that's still acceptable. Alpha blocker, or just similar to the beta blocker, because you can also call them as beta adrenergic. So I usually just get rid of the adrenergic because it's actually safe to say just without the adrenergic component. But yeah, it is an antihypertensive medication. So again, what do you expect? if you're going to give this medication to this patient, especially if this is new to them, this is their first time to take this medication. Well, of course, it can lead to orthostatic hypotension, and this is something that you need to watch for, especially that your patient is elderly. Yeah, they are prone to developing falls, and this would really cause this to happen in so many patients, especially in the nursing home. There's a high incidence of falls because of so many medications that can cause their blood pressure to drop. The patient gets dizzy, and all of a sudden, when you go back to their room, the patient's already bleeding in their forehead. Or maybe they end up with some rib fracture because of that fall. You got to be careful, guys. And so this is something that you need to keep an eye out in order that you can mitigate this problem. So if you've forgotten what is orthostatic hypotension, basically this is the sudden drop in the patient's blood pressure upon standing. So most of the time when they're sitting on the chair, the wheelchair, or maybe laying in bed for longer periods during the day or the nighttime, so by that time when they're going to use the bathroom, when they stand up, that's the time that the blood pressure will suddenly drop and could cause them to get dizzy, and they're going to be down on the floor. Dizziness, yes, it's going to go together with orthostatic hypotension because there is a drop in the blood pressure and there is a decrease in the blood supply to the brain, and that is why they're going to end up with a dizziness, okay? Because of that hypotension. There is a lack of oxygenation to the brain. That's why they're going to complain that. Maybe they'll feel like the environment or the surrounding space is kind of revolving or rotating around them, or they feel like it's spinning. And so that would be that classic subjective cue that they'll report. Now, there's also headache, there will be fatigue, nasal congestion, and also there will be retrograde ejaculation. Do you know what this is? Retrograde ejaculation? Well, this is actually a side effect wherein the semen will enter the bladder instead that it will emerge through the penis during ejaculation. So it's kind of weird that it's actually going up into the urinary tract instead of leaving the urethra. Kind of weird. And so this is something that you need to talk with a patient. And so, yeah, we're actually going to talk about the nursing care right now. So what do you do? Again, make sure that you do your assessment and monitoring the patient's vital signs, especially the blood pressure and also the heart rate. You got to do that orthostatic blood pressure measurement wherein you're going to have to check the baseline vital signs when the patient is flat in bed. So you have to check the blood pressure, their heart rate, and then you're going to assist them to a sitting position, and you're going to wait for at least 5 minutes, and you're going to measure the blood pressure and the heart rate one more time. And then you're also going to assist them to stand up to check another set of the blood pressure and their heart rate. And so if there is a significant drop, let's say 10 points drop from each reading, let's say, for example, the blood pressure when the patient was supine, maybe, let's say, 130 over 85. And this is supine. And then when the patient was sitting upright, probably their blood pressure now is about 120 over 80. And then when they stood up, probably it went down to 105 over 75. So look at the differences here in the systolic readings. That's actually 10 points each, right? And so that is a significant drop. So this is what's going to help you tell that there is orthostatic hypotension. And together with that, when you're going to look into the heart rate, so let's say, for example, when the heart rate during, when the patient was still in a supine position, let's say the heart rate was 82. And then when they were sitting at the side of the bed, probably the heart rate went up to 95. And then when they stood up, maybe it went up to 105. So as the blood pressure goes down, the heart rate will go up as a compensation for that drop in the blood pressure. And that would really going to help the diagnosis, or let's say determine that the patient has positive orthostatic hypotension. And this is something that could come out in your exam. The NCLEX is so tricky that it will ask you even the simplest question. It will gauge how well you're going to be able to capture these subtle manifestations, okay? It's not going to really ask for the difficult questions. It's just going to measure if you're going to be able to analyze the scenario, if you can operate, if you can synthesize the knowledge that you have gained. It's how critical the NCLEX is. It's not knowing really the basic knowledge base. No, it's going to ask you how you're going to be able to synthesize all those learnings that you have gained, okay, and how you're going to be able to apply it. And so back to the orthostatic hypotension. This is really critical, especially when you're starting the patient with this new medication, any antihypertensive medication, alpha blockers, beta blockers, calcium channel blockers, ACE inhibitors, and a whole shebang, maybe diuretics. You've got to be careful. Check your patient's blood pressure, especially the orthostatic vital signs. All right? I hope that you're able to get that. Now, we're going to talk about the, since we're talking about the implications here, aside from monitoring the blood pressure, we're also going to teach the patient to avoid sudden positional changes. Like I've said, when probably you already determined that the patient is positive for orthostatic hypotension, then you're going to have to teach them, remind them that before they get up from the supine position, they need to slowly shift their position. So before they're going to stand up, make sure that their feet is planted on the ground, okay? And they kind of wiggle their toes, maybe wait for a good 5 minutes, keep that circulation going before standing up, or maybe have a walker right in front of them, or maybe a cane in order to help them out just in case if they get dizzy. And so this is something that you need to teach them to avoid sudden positional changes. It always accompanies in the prevention of the orthostatic hypotension. Now, also check for any dizziness. So keep asking your patient, are they feeling some sort of dizziness when they moved around after they started taking the medication? Always ask them, okay? We are going to promote patient safety, and this is one of the test questions that we're going to be asked in the NCLEX. Safety, reduction of risk potential. So if you're not going to be able to maintain that safety in your patient, you're not going to be able to pass the NCLEX, trust me. And this is something that I actually learned because back in the nursing school, we were not taught really well on actually preventing these risks. And this is true. Most of the nursing schools are not really teaching about the prevention and also mitigating the risk factors. And so this is really what the NCLEX will ask you about if you're going to be able to properly promote safety in your patient. Now, another is to caution your patient for any activities that will require mental alertness, such as driving their car, or let's say operating hazardous machineries, maybe what kind of hazardous drills, or maybe chainsaw, those kind of things. What else? Anything that would really require mental alertness you would have to caution your patient that they will not have to do this when they're taking this medication up until they're safe to do so, okay? Now, we are going to assess the patient's liver and the renal issues as well, because they tend to affect these liver and also the renal functions. And also make sure that you are going to educate the patient for the retrograde ejaculation. This is something that should be talked with their medical provider. Maybe there's something else that they can do for this patient. And also we're going to talk about the 5-alpha reductase inhibitor. So what is this group of medication? This is a new classification or a different classification with the different generics here. We have the finasteride and also the dutasteride. So take a look into the suffix here. Deride, finasteride. Those are the 5-alpha reductase inhibitors. And so these kind of medications will actually block that enzyme that will convert testosterone into DHT. And so that will allow to, that will enable to shrink the prostate and also to ease the urinary symptoms by lowering the DHT. And so this is going to be an effective medication in order to facilitate reduction of those symptoms. And you got to pay attention here because there are also side effects that are going to lead to that, such as erectile dysfunction. So for those patients that are still active sexually, they need to bring this up to their medical provider in order that this is going to be addressed as well. And there will be a decrease in their level of libido, okay, or libido. All right. Now, we're also going to be concerned about complaints of gynecomastia, wherein there is going to be enlargement of the male breast tissue. And this is going to dissipate when there is a, when the medication is discontinued. But of course, we're not really going to expect the patient to discontinue this medication right away without the approval of the medical provider. And so this has to be talked at length between the patient and the medical provider. Now, we have to include this in our nursing patient interactions and also monitor for any kind of sexual dysfunction. So don't hesitate, ask this patient about possible changes in their sexual libido or dysfunction, maybe erectile dysfunction, and also educate them about the possible side effects. Okay, so they will be able to expect those, and also that they will be able to report to the medical provider in a timely manner, and make sure that we are also looking into their liver function testing to see if there's any rapid change, and also to make sure that we are educating the patient to report any enlargement of their breast tissue. Now, moving into another group of classifications of medication, we have the phosphodiesterase 5 enzyme inhibitors, and these are your known Viagra, Cialis, the sildenafil. So take a look into the suffix. Okay, so they're not really prescribed to treat the ED or the erectile dysfunction of our patient, but basically they are ordered or they are prescribed to also cause relaxation of the prostate muscles. It will allow that smooth muscle to relax in order to allow that urine to flow into the urethra. Okay, it will really improve the manifestations, and it can also enhance their erection. Okay, so it will also treat the erectile dysfunction in this age group. But you got to be careful though, because some of these patients might end up with priapism, which is basically an extended period of erection. It could last for 24 hours. Some of these patients could have an erection for 48 hours, and it can cause ischemia into the penis. And because of the stiffening of the tissue, it can compromise the blood supply. And so I had one patient, actually it wasn't an older person, it was a young adult, and I don't know what he was doing, but he probably was experimenting, but he ended up with some incision and drainage of the penis just to drain the congested blood. And yeah, that was the deal. And so you got to monitor for the side effect of this medication. So one of those is orthostatic hypotension. So keep that in mind. Those Cialis can cause orthostatic hypotension, and it can lead to dizziness and headache. And there's also going to be fatigue and retrograde ejaculation. So please take note of these sexual dysfunction and weird side effects. Now, we're going to have to check our patient, especially before we initiate the therapy. We have to thoroughly ask our patient if they are using any nitrates. I'm talking about prescription medications, those medications that are used to treat angina pectoris, okay? Those are medications that can cause vasodilation, which can also cause a drop in the blood pressure. So if they're going to use this medication along with the nitrate, they're probably going to end up dying, or they're probably going to die in the middle of a sexual intercourse because of the drop in the blood pressure. They're going to end up with an MI because of the lack of blood supply. And so make sure that you investigate thoroughly what medications that they're using at home. If they're not being truthful to you, then what you can do is to also get a look into their medical records to see if they are using some nitrates or some medications that might cause vasodilation, because this can really harm them when used concurrently. Okay. Now, also teach the patient to report any potential visual disturbances. Okay, because if they're gonna end up having those, this probably could lead some more irreversible problems. And it could be in a form of, let's say, visual disturbance that can be exacerbated by this classification. Let's say the retina's ability to respond to the light can really be aggravated. It can progress into a vision loss, or maybe if they had some kind of optic neuropathy. This is also associated with vision loss, so make sure that you are screening your patient before this medication is initiated. Okay, and for those patients that have history of glaucoma, this is not supposed to be taken by this patient when they have glaucoma, because it can increase their intraocular pressure. Okay, again, for those patients that are going to be prescribed with the phosphodiesterase 5 enzyme inhibitors, this is not going to be safe for them to take if they have glaucoma. So check your patient's history. Now, they probably would be also complaining of some transient side effect like headache and flushing, and this is something that can dissipate. So what they can do is to, if they're really going to be bothered with a headache, you can teach them to take a regular Tylenol as needed to relieve the headache. But yeah, tell them that this is a transient side effect that can disappear after several weeks of therapy. Now, have them report for those visual disturbances that can start to occur when they take this kind of medication, because it can complicate things, such as the glaucoma. Now, we'll talk about the anticholinergic medications, all right? So, guys, I'm just going to caution you right now. The anticholinergic agents are not the mainstays of the treatment in the BPH, okay? It will not. The only reason that I included the anticholinergic agents, it's because these medications can control the manifestations of overactive bladder, OAB. And this overactive bladder can accompany this problem, the BPH. And so most of the time, the medical provider will end up ordering the anticholinergic to treat the overactive bladder. It's not to treat the enlarged prostate. It doesn't cause relaxation of the smooth muscle, okay? And so, yeah, it has a different indication, but I just included it here because it's going to be, this is a problem that will also occur in this BPH patient. Now, what are the examples of the anticholinergic agents? So what are these meds? Well, these are your ditropan or the oxybutynine, and there's also the detrol or the tolterodine, and this is going to be common. And mind you guys, when I started working in the med-surg, there are so many medications that I was even familiar that I did not even hear during my BSN years. Never. And so you always have to guard yourself with the drug handbook. Don't be embarrassed to look into the drug handbook when you're going to be out there as a newbie. You're going to have to cover yourself. And trust me, not all nurses, even long-term nurses, know all the medications. Trust me, they don't know everything as well. So it's such a safety measure when you really have to check yourself. Refer into the drug handbook if you're not sure. Always do that. Okay, that would be my reminder. Don't assume that you know everything, because you're gonna catch yourself committing an error, which can be detrimental to your patient. Now, another is the vesicare. This is the solifenacin, and this is also going to help treat the overactive bladder. Now, the action of these anticholinergic medications, again, this is not to cause the relaxation of the prostate gland, but what it can do is to block the action of the acetylcholine. And when this happens, when that acetylcholine effect is blocked, it can now really relax the smooth muscle, but not to the same degree that it can do compared to the other three classifications. Now, let me erase that because it's blocking the view. Wait a second here. It can also reduce the frequency and urgency of their urination. Okay? Now, the patient here is probably going to experience some of the more common side effects, like dry mouth. Guys, pay attention. We're talking about anticholinergic drugs. Dry mouth is a common manifestation to the anticholinergic. Actually, when I was studying in the NCLEX, I labeled the anticholinergic medication as dryers. It will cause drying of your oral secretion. It can also cause constipation. It can really cause slowed peristalsis. So constipation is our expected side effect. And there's going to be retention of the urine. So basically, look at the side effect here. Urinary retention. This is not the goal that we want in our patient, right? Especially that we are dealing with a patient with a BPH that has already a urinary retention. And so take a look into the side effect. That is why some of these patients might end up having one of the 4 classifications plus this anticholinergic agent in case they might have an overactive bladder. Okay, so this is not really a substitute to treat the prostate hypertrophy. All right. Now, another thing is that they're going to end up with blurring of vision. And this is another common side effect in an anticholinergic medication. So please don't forget your decub. I probably would make a mnemonic here. Decub, dry mouth, constipation, urinary retention, and blurred vision. Probably that would help you a little bit. Decub, dry mouth, constipation, urinary retention, and blurred vision. Now, how are you going to, wait, there's another one. For those elderly people, might end up with some confusion. So you got to be careful. Assess their baseline cognitive function to see if they're with it or they are already confused. If they probably have Alzheimer's, maybe they have dementia already. And so you really need to keep an eye into these patients if there are any changes in their cognitive function, if they have that or not. Or there's going to be an increased risk for a heat stroke because they will lose that ability to feel that they're losing lots of the body fluids, especially when they're out in the sun. Now, what we're going to do here is to also assess the patient for a possibility that they might have a history of a glaucoma or urinary retention. So this is something that you need to investigate, okay? Another medication that you need to watch for, especially they have glaucoma or urinary retention. You have to monitor them if they're going to develop anticholinergic toxicity. So what is this? They're going to experience some confusion, delirium. Yeah. Again, you have to check the patient's baseline cognitive function before you start this new medication, because again, this can lead to these problems. And make sure that you're also going to educate the patient about the side effects, about controlling the dry mouth. So what you can do is offer them or have them at least have a sugar-free candy in order to relieve the dry mouth, or increase their dietary fiber in order to prevent the constipation. So these are common side effects. And again, NCLEX would like to ask these simple questions. Very easy questions, but sometimes you will neglect this. So I would rather have you dig deeper into the basic nursing, those kind of nursing interventions that would really keep our patients safe. The basic ones are actually, those are the common ones that would come out. Yeah, when I was actually, because I'm licensed in the Philippines, also as a registered nurse, and before I migrated to the US, we had to take the CGFNS, which is basically the Commission of Graduates of Foreign Nursing School. So this is a set of, this is an exam that we have to take for those graduates from the Philippines, outside the US. We have to take that, but it's no longer required nowadays. But way back, before we can take the NCLEX, we have to take the CGFNS. And the CGFNS is actually patterned to the NCLEX, pretty much the same, actually. I mean, the same requirements, the same type of questions, and also those different parts of the test, like risk reduction, physiologic integrity, pretty much everything is patterned. And so my lowest score was actually in the risk reduction. I was so mad that even the simplest questions, I committed errors, but I passed the test way beyond the passing rate. But yeah, again, you don't neglect the fundamentals of nursing, those interventions that can keep our patients safe. Again, don't neglect those. And so we're also gonna caution our patient to avoid activities that can cause dehydration, let's say working outside or being exposed out in the sun, gardening maybe, so, or maybe doing a very strenuous exercise, then they need to refrain those. Maybe they can substitute those kind of activities with something else. All right. Now we're going to proceed with the next modality of treatment here for the BPH. And one is the surgical procedure, such as the transurethral resection of the prostate. Okay, so that's the TURP. And this has been an old procedure that is still being used nowadays. And so this is the standard treatment for the bladder obstruction in the benign prostatic hypertrophy. Okay, so the procedure will actually involve the insertion of a scope into the urethra in order to remove the prostate tissue, and it will give relief of the symptoms of the prostate problem. And this is something that can also be used for those patients that may have prostate cancer. And what you're going to watch for this after the patient comes back from the procedure is the bleeding. So I'm just going to show you real quick about what this TURP really is. So this is an invasive procedure. Of course, you're going to have to obtain the patient's consent, also prepare the patient to make sure that they're NPO before they go for this procedure. And this will involve the instrumentation of this device that will be used by the renal doc and or urologist, and they're going to have to approach the prostate through the urethra. And this is something that is invasive and could do a lot of bleeding post-operatively. And so this is what we're going to do. We're going to watch for significant bleeding after the procedure. And we are going to encourage the patient to take in this much of water every day, at least 2,400 mLs to 3,000 mLs if not contraindicated. Okay, and the reason for increasing the fluid intake is actually to flush the urinary system and also to make sure that we are getting rid of those bleeders and to prevent those clots from forming. Now, the patient is going to be placed on the continuous bladder irrigation, which is something that the topic that I'll be talking about the late part of this discussion. And so this is going to involve a continuous irrigation, okay? And we'll talk about this later. And of course, we're going to check the patient's urinary output while they're going to be on the irrigation. We'll have to observe for the kind of drainage the patient will be having, watch for the color, if there's any clots, or maybe if there is an obstruction. Because if there is a decreased flow in the bag, then something is not right here. Maybe there is a clot that is clogging the system. All right. Now we're also going to check for the transurethral resection syndrome. Kind of fancy sounding, right? And so this is something that can happen readily, wherein the patient will experience high blood pressure. There's also going to be bradycardia, and they will get confused, disoriented. There will be some muscle spasms. There are going to be some visual changes and nausea. Oh, sorry. So these are the manifestations that you really need to keep an eye on. This is caused by the significant crossing of the irrigant into their system, causing hyponatremia. So these are possible signs of a hyponatremia. It's kind of weird though. Well, because the patient has hypertension because the fluid that is irrigating has now probably gone through the systemic circulation, adding to that volume. Of course, diluting the sodium level. That's why there's hyponatremia. And then the confusion and disorientation is associated with the hyponatremia as well, and the muscle spasms. So this is something that you need to keep an eye on when you are dealing this patient with continuous bladder irrigation. Now we're going to talk about the next procedure, which is the open prostatectomy. So this is a invasive test or invasive procedure that will involve lower abdominal incision, and there's going to be manual removal of the enlarged part of the prostate. So this is going to be done this way. Once the incision has been created, the surgeon will be manually removing that section of the prostate. Yeah, kind of like, hey, what are you doing there? You're just kind of like scraping with a gloved hand. It's kind of interesting. And so basically, once that incision has been established, there will be the surgeon will access the prostate gland through a standard incision, and they're going to have to grab that portion of the prostate gland. So once the patient is going to return to your unit, of course, you're going to check the patient's vital signs, right? And this is possibly going to cause some bleeding, and you're going to watch for the blood pressure, the pulse rate, respiration. And this is a painful procedure, so expect that your patient's going to be in pain. Get ready with your analgesics, and you're going to have to take care of the patient's wound. Make sure that you're going to keep the surgical area clean and dry, and have to change the dressing as needed, as ordered. And we're going to have to keep an eye for any signs of infection, like redness, swelling, discharge, and also the dehydration. All right, you have to really prevent those from happening. You got to make sure that the patient is receiving adequate fluid intake and adequate nutrition in order to properly heal the incision. Now, you also need to promote proper catheter care in order to prevent introduction of the microorganisms. And this is going to require you to do regular daily cleaning around the insertion site and to monitor for any signs of infection or, let's say, blockage. Now, this is also probably going to require the continuous bladder irrigation. And once it is required, let's say a CBI or continuous bladder irrigation is ordered, Make sure that you're also monitoring the irrigation system. Make sure that it's functioning well. There's no blockage. You're going to have to regulate the flow of the irrigant um, depending on the color of the drainage. All right. So if there is, let's say, presence of clots, or let's say bright red bleeding, or let's say dark red bleeding, what you're going to do here is to open the clamp much wider in order to allow irrigation. And then once the color goes back to pinkish, then you're going to have to slow down the rate. Not really slow down, but just to make sure that the pinkish coloration is maintained. Okay, because what we're really wanting to prevent here is the clotting. We don't want that. Now, when the patient is ready to ambulate, when their strength is back, then definitely encourage them to move around in order to prevent the formation of DVT, also to improve their circulation. Now, our education for this patient with the open prostatectomy is to, again, this is a highlight here that you need to keep an eye out. Prostatectomy patient, especially with the open type, you're going to restrict them from doing any strenuous physical exertion. This is the key. Avoid or restrict the patient from doing any strenuous activities, because this can cause an increase in the abdominal pressure, which can also disrupt the surgical site, and it will cause bleeding or hematoma formation into the surgical site. So that's why we don't want any of these strenuous exercise for several weeks. We're talking about 3 to 4 weeks. All right. Now, there should be no bathing or swimming, because if you're gonna allow the patient to do this at home, if they're gonna immerse themselves into the bath, the tub bath, this will immerse the surgical site in the water, which can introduce the bacteria and also increase the risk of wound infection. So they can only do the showering, of course, covering that surgical site with a plastic cover in order to protect the surgical site from getting wet. And also swimming is also contraindicated for the same reason. And we're going to have to monitor the patient's urinary output in order for us to keep track to ensure the proper functioning of the kidney, so that we can tell that maybe the kidney is really not producing enough urine, or maybe there is now oliguria or anuria. So that is why it's very important for us to include this in our teaching when we send our patient back to their homes or back to the nursing home or their assisted living facility. Okay. Now moving into another procedure, which is the, what did we just say? Okay. The suprapubic prostatectomy. Okay. So this is basically a procedure that is going to remove a significant portion of the prostate gland with the incision on the abdomen and also the bladder. Okay. And so this is another invasive procedure. And this will really require you to do frequent dressing changes, because this can cause some leaking of the urine. Okay, again, you're going to do a lot of frequent dressing changes post-operatively, because the patient will be releasing large amounts of urine that will really require frequency in dressing change, of course. You don't want the site to get wet and cause maceration into the tissue. And you don't want bacterial growth as well. So you want to make sure that you keep an eye out into the site until it's fully healed. All right. Now, this procedure it will give a higher risk of bleeding. And so you're going to keep an eye out for any blood loss and making sure that you're looking into the dressing change. Talk to the patient if they're quite with it, or maybe the caregiver. Tell the caregiver to keep an eye out into the dressing site to see for any blood loss. Okay. And at some point, maybe the doctor would want this patient to be conducted to a continuous bladder irrigation. Then that is something that we need to take care as well. If the patient will be complaining of some bladder spasms or overactive bladder, then definitely we can administer those prescribed medication as well. And also keep an eye out on their urinary output to check for the kidney function. We have to check for any signs of blockage. Maybe there is formation of clots post-op. And so this is going to be concerning and needs to be reported to the medical provider right away. Now, another procedure that we probably encounter during the test is the retropubic prostatectomy. And so in this approach, the prostate gland is going to be extracted through a lower abdominal incision. And so there will be no incision in the bladder, just in the abdomen, okay? And so this is what it's going to look like. Let me zoom that. Again, there is no incision in the bladder, but only in the abdomen. So look at that. This is the bladder right here. I can't really use my pen right now when this is zoomed. And so the bladder right here and the prostate gland that is enlarged, and this will be manually going to be extracted by the surgeon. They're going to get rid of that excess prostatic tissue, and then they're going to remove it, of course. And then they're going to end up with that urinary catheter, which is the three-way, to allow the continuous bladder irrigation post-op. All right. And so with this procedure, this is going to require us to do vital signs monitoring as well. And this is going to require the use of the bladder irrigation. And again, we're going to talk a little bit more of that, of this procedure after. And keep an eye out for any pain. Pain is always something that we can manage. However, though, if there is pain that is not going to be relieved by the current prescription, this is something that would really be a red flag. It could be something else. Maybe if there is an associated bleeder going on with the intensity of the pain that they might be complaining, then that is worrisome. So you got to report this right away to the medical provider. And you're going to assess for the drainage as well. Make sure that the drainage is within the acceptable range as far as the volume and also the coloration of the drainage. So again, if this is a patient that is post-op, a fresh post-op patient, so we're going to maintain that pinkish coloration, light pinkish coloration. We don't want any clots to form at all when the patient has this kind of procedure. Now, part of the care here is to make sure we are providing wound care, prevent any kind of infection. We're going to have to assist the patient with their mobility, make sure that we are going to provide them with adequate nutrition and educate the patient for any possible symptoms of infection. That is a big deal. Now, another procedure that we need to talk about is the perineal prostatectomy, which is basically like that. And so the approach is going to make that incision between the anus and the scrotal area. All right. Kind of odd kind of incision. It's kind of curved. And so this is going to cause minimal bleeding, okay, they say. But because of the location of the incision, the patient really is at a higher risk to develop infection because of the proximity to the anus. Again, infection control post-op is challenging in this case, all right? Now, we're going to have to monitor the patients for any signs of infection post-op with a wound. That would be kind of challenging if I'm going to be the nurse assigned to this one. So we have to check their vital signs, capture for those subtle changes in the temperature, heart rate, blood pressure for any signs of infection, and also to check for bleeding. There will be an expected minimal bleeding, but who knows? If there is a bleeding, I'll consider that as a bleeding. And so keep an eye out on that. Keep an eye for any manifestations of infection. Redness, swelling, increasing pain to the surgical site, could be warmth, drainage of purulent characteristic. These are the things that we need to report right away to the medical provider. Now, part of that is to manage the urinary incontinence. This is going to be a problem for this patient after they have a perineal prostatectomy, okay? And the reason why they're going to have the incontinence, it's because of the disruption of the urinary sphincter. Okay? So they will lose that ability to hold their urine temporarily. Urinary sphincter disturbance. So they're going to be incontinent. Okay? So what are we going to do to deal with this problem? Well, we're going to have to monitor their urinary output, and we have to track their patterns and take note if they have massive incontinence or probably they are retaining. We're going to have to incorporate bladder training. So how are we going to do that? We're going to have to check on teach them to do the Kegels exercises, the pelvic floor exercises. This would really help out in combating the urinary incontinence. Again, monitor the urinary output, bladder training, and plus the use of incontinent products or incontinence products to prevent leaking into the other skin sites. So we want to make sure that we're also changing the incontinent products often to prevent any sores, and make sure that we are going to teach them about the Kegels exercise. And this is really going to strengthen the muscles that control the urination. Okay. Again, this is a temporary complication, the urinary incontinence. Okay. Moving into the procedure of the continuous bladder irrigation, and this is the fun part. Okay. I've done so many CBIs in the med-surg setting, and it can be challenging sometimes if your patient is confused. Yes. I would be happy to have 2 bladder irrigations in one shift, 2 different ones if my patients are alert oriented. But if your patient is confused and they don't have somebody to watch them, their family member is not available to stay with them, or maybe the nursing unit doesn't have a budget for you to have a sitter to watch the patient, yeah, that would be challenging, because if they're confused, they dislike the presence of the catheter, they're going to end up pulling out the 3-way catheter, and they're going to end up with some more bleeding, and they're probably going to rip off those IV axis. And yes, I've heard horror stories about patients ripping off their 3-way catheter. So we'll talk about the continuous bladder irrigation. So basically, let me show the picture here first. So this is the setup here. So what you're going to expect in a bladder irrigation is that there's going to be that big bag of normal saline solution. This is not your regular IV bag of 1 liter. No, it is a huge, huge bag. It's heavy. And this is going to be sterile, normal saline solution. It has a special setup wherein you're going to have to use that adaptable kind of tubing that you can use to spike that bag. It has a chamber, it has a clamp, and the tubing is large enough. I mean, I'm talking about the diameter. It's totally different. It's not the same kind of tubing that we use for the IV fluids. And it will be connected into one of the ports into the 3-way catheter. And so here's the cross section of the catheter. It has 3 lumens, right? One is for the irrigating channel, one is for the retention balloon, and the other one is for the drainage channel. So the ones that you are seeing in a regular patient with a Foley catheter, that's not it. No, that's only the 2-way. So for the 3-way irrigation, again, one of the ports will be intended for this irrigant. The other one is for the balloon, and the other one is for the drainage. Now, the patient will be, of course, during the acute phase. After the procedure, the patient will be in bed most of the time. We're going to have to make sure that the drainage bag is secured hanging into the rails, or not really the rails, but the side of the bed frame. And make sure that the bottom part of the bag is not touching to the floor, because, again, this will become a medium of infection if we're going to allow the bag to drop onto the floor. We don't want that. And especially when you're emptying the bag itself, you got to be careful that this tip right here of the drainage bag will not touch into the graduate, the container that you'll be using to measure the amount of urine and the drainage output. So you got to measure that you're disinfecting the tip of the bag in order to prevent an ascending infection. Okay. Now, supposedly, guys, this picture is not really that perfect. This is right here, this section where the tubing is. It should have been in the picture, should have like a tape that is going to secure it into the abdomen or into the thigh in order to prevent untoward dislodgement, or let's say movement of the catheter. Because if there is movement of the catheter, then this can also affect the integrity of the incision into that incision inside the bladder. So we don't want that to happen. That's why we're going to have to secure that with a tape into the abdomen and into the patient's thigh. So I cannot find a perfect picture. And so that's the only thing that I can find in the website. Now, our responsibility here is to really keep that traction. Okay, so what does that mean? Maintaining catheter traction. This is basically gonna what you're gonna do here is to tape the catheter tubing to the abdomen, and again, this is to prevent bleeding, to prevent untoward movement of the catheter that can cause bleeding inside the urinary bladder. That's why we need to keep that. And then we're gonna instruct the patient to keep the leg straight if traction is applied. Keep the leg straight. So they can still move their legs, but just not bent, okay? Make sure that they can do a lot like lateral movement, but not bending, not a whole lot of that. Now, what we can do here, especially if there is that restriction, in order to prevent the possibility of stasis, or let's say DVT, in order to prevent from having that kind of complication, we want to make sure that we are applying the sequential compression device. I don't know if you are familiar with that, SCDs, sequential compression device. This is not the same as the TED hose or compression stocking. This is going to be a synthetic material that will be applied, that will be wrapped around on each leg or thigh to cause intermittent massaging. And this is going to be connected to a machine to cause that intermittent pressure into the leg. And this is going to cause circulation of the blood into the lower extremities. So that's the SCDs, to prevent stasis of the blood, okay? Because our patient really here is at risk to developing blood clots, especially if they just came back from surgical procedure. If their mobility is somewhat restricted, then you have to do something about it. Now, what we're going to do here is we are not supposed to release the traction without the medical provider's order. Do not do that. So make sure you get a permission to do that, or make sure that you have a reason to release the traction, okay? Now, also, you're going to have to follow with the prescribed irrigation solution. So most of the time, this is going to be the standard irrigant, sterile, 0.9% normal saline, okay? This is sterile. It has to have the same osmolality with the body. We're not going to administer sterile water, no sterile water, because it is hypotonic. We don't want that kind of fluid to get into the patient's system. It can cause dilution, all right? It can cause hyponatremia. So what we're going to do, we're going to have to use the sterile normal saline solution, 0.9%. And again, they come in big bags, okay? Like 4-liter bags, I believe, if I'm not mistaken. Yeah, those are heavy ones. And you have to secure at least 6 to 10. Yeah, I've ordered so many just for this patient that was post-prostatectomy. Now, we're going to have to adjust the rate of the irrigant, okay? This is something that you have to observe, really. So what you can do is adjust the irrigation rate in order to keep the urine pink. This is going to be our goal, urine to be pink. So if the the color of the drainage becomes bright red, or if there's any clot formation, then what we're going to do, we're going to have to increase the rate of the irrigation. And if there is such thing as, let's say, obstruction of the outflow, maybe you're not getting any more outflow. So let me enlarge the picture over here. So for example, right here, we're focusing into the bag right now. So by the time that you have emptied the bag, because it was already full, and then it's been probably 2 hours or 3 hours, and you're not seeing a whole lot of drainage coming out, even though the rate of the infusion is really fast, then you're going to start worry here. Even within just an hour period, if you observe that, suspect that there could be some obstruction in the irrigation. Okay, so if this happens, if there is any obstruction, what you're going to do here is to probably irrigate that with at least 30 to 50 mLs of normal saline. And most of the time, when there is an order for the continuous bladder irrigation, we're going to be given a PRN order along with the standard irrigation. We're going to be given an order to irrigate the site if there's blockage, and we're going to have to discontinue the continuous bladder irrigation. At that point, so this is, let me backtrack here. So by the time when there is blockage, you're going to turn up first the CBI, okay? And then after that, you're going to have to deal with manually irrigating the system, okay? And if it's resolved, if there is now an outflow, then you can proceed with the CBI. However, if you're not going to see any resolution after you had tried to manage the blockage, then you definitely need to notify the surgeon, okay? That is your call. Do not reinstate the irrigation if there is no outflow, okay? You've got to notify the surgeon for that. Now, if in case it's been probably 48 hours or 24 hours after the prostatectomy, then by standing order, sometimes we'll have an order to discontinue the irrigation as ordered. Okay, so this is expected. So at this point, the patient probably now has much lighter coloration in their urine. It's no longer pinkish in color or maybe reddish. So it's light, kind of like close to light yellow or straw-colored urine. Okay, and sometimes you can still see some residual clots, which could be present at that point. Now, what you're going to do here is to monitor the patient for a possibility that they're going to be incontinent and also some urinary retention. So when you're going to, after you remove the three-way catheter, make sure that you are going to check for their retention. By how? Maybe the patient will complain that something is, that their bladder is full, that they still need to urinate, or use the bladder scanner in order to determine the retention of urine. So you can do that, okay? Now, another thing is you're gonna warn the patient ahead of time about possible burning, frequency, and dribbling after the removal of the catheter. And this is something that is expected, okay? Burning, frequency, and dribbling. And so it's very important that bladder training should be done before we actually remove the catheter. Have you been taught how to do the bladder training way back in the nursing school? Have you done this before discontinuing the catheter of the patient? If not, then it's time to review on that concept, because bladder training is actually a procedure wherein you're supposed to clamp the distal part of the catheter for, let's say, 4 hours. And then after 4 hours, you're going to release the clamp. And this will cause the bladder to return to its kind of like muscle function. And so this is something that can also stimulate the return of their detrusor muscle integrity. And so this is something that you got to do. Make sure that you have to allow the training to occur before the discontinuation. Okay, so let's proceed here with our patient education. So part of the care here is ask the patient to void about 150 to 200 mLs of clear yellow urine every 3 to 4 hours by the third day post-op. Goals, right? Every 3 to 4 hours, ask your patient to urinate at least 150 to 200 mLs of clear yellow urine. So this is actually going to encourage the patient to achieve that goal. Make sure that they're going to take in that adequate amounts of fluids orally so that they can urinate every 3 to 4 hours. And this is going to prevent bladder distension and also make sure that they're going to reduce their risk of urinary retention. Okay, and also to avoid the complications. Now, also teach the patient to avoid the following strenuous activity. Another instruction: risk reduction. Teach the patient to avoid lifting heavy objects and also strenuous exercises, Valsalva maneuver, bearing down when they're passing hard stools, and to avoid sexual intercourse for about 2 to 6 weeks. Okay, this is something that you need to emphasize to this patient in order to prevent injury into the incision. Okay, make sure that they're not going to do any of these during the time frame, 2 to 6 weeks. Now, also have the patient notify their care provider whenever there is bleeding that's going to occur when they're going to be sent home, or if there is a decrease in their urinary output. That is a problem. So they need to notify the medical provider as early as possible when they have these manifestations. If they're going to feel discomfort, feeling that they're not really emptying their urinary bladder, those are important stuff to be reported right away. And also encourage your patient to take in at least 2,400 mLs to at least 3,000 mLs of water per day. And this is to be done during the daytime. And the reason for that is to allow flushing of the urinary system and, of course, to prevent nocturia. So it has to be consumed during the daytime, not at nighttime. Okay, or else they're going to end up with nocturia. Now we're also going to testing. Okay, but I actually have some add-ons here. And so we're going to have to instruct our patient, teach them about avoiding the regular drinks that they used to do before: alcohol, caffeine, spicy foods, and also any of those irritating to the bladder, because this can cause their bladder to become hyperactive, overactive. This can cause those painful spasms as well. So make sure that they're going to avoid these food items. Now, what are we going to do here? We're going to answer some of the questions. So again, I really encourage you to participate here. Put in your answers in the comment or in the live stream chat. You can do that as well. We're actually reading your comments. So time to answer this situation. Question number 1, it says, after a transurethral prostatectomy for benign prostatic hypertrophy, a patient undergoing continuous bladder irrigation reports increased bladder spasms. What should be the initial action? Is it letter A, cease the bladder irrigation and notify the physician? Or is it B, assess for the presence of clots and confirm adequate catheter drainage? Or is it C, administer acetaminophen? Or D, provide indomethacin suppository as per physician's orders? What is your answer? So the patient has increased bladder spasms while on the continuous bladder irrigation. So what would be your initial action? Is it A, B, C, or D? Take your choice. Okay, I hope that you're able to answer that one. So let's go by the first option here. Cease the bladder irrigation and notify the physician. What do you think? Do you think it's a good idea to stop the irrigation while they're having spasms? Probably not. And so the reason for that I'm not going to select this as an answer, because when you're stopping the infusion or the irrigation, it will cause the complications to set in. It can now allow the blood to clot. It can cause more retention in the bladder. So we're not going to recommend stopping of the irrigation at this point, okay? Just for the bladder spasms. So this is not recommended before we had done the other stuff. So what about letter B? Assess for the presence of clots and confirm adequate catheter drainage. Did we talk about this? I believe so. We're going to pick letter B as our possible correct answer. It is because the increasing bladder spasms, this is going to signify that there is a presence of clots. And so we want to make sure that we are thoroughly assessing this. Make sure that we are continuing the bladder irrigation. Make sure that we are looking into troubleshooting, okay? If there's possibly some increasing clot formation, we're going to have to increase the rate. And also, if there is now a decrease in the outflow, this is the time that we're going to have to do the irrigation. Stop the CBI temporarily, and we're going to have to irrigate the catheter, okay? And once it's resolved, we're going to have to continue again. So that is our first assessment action. So what about letter C? Administer acetaminophen. We are probably going to give the acetaminophen, but again, we need to do the investigation first, okay? So you can provide the patient or administer the acetaminophen as ordered, but again, always check the patient first because of that problem that they are complaining about, the spasms, okay? So you're going to look into the blockage first or the clot in the catheter. So the medication can treat, but it can wait a little bit after you have dealt with the blood clot issue. Now, what about letter D? Administer indomethacin suppository per doctor's order. Well, this is a step that that can relieve spasms. Yes, that's true. It can help. But again, it is important for us to really do our assessment first for any mechanical issues, maybe the presence of clots or drainage problems that might be causing the spasm. And then after that, we're going to have to start dealing with the pain, make sure that we are addressing the spastic type of bladder spasm pain. Okay? So again, what is your strategy here? You're going to have to prioritize your assessment first. Gather as much as information that you can have before you're going to do your intervention. Make sure that the interventions that you're going to do for this patient is appropriate and it's really targeted to the actual problem. Because if you're just giving them an analgesic, acetaminophen, or let's say the indomethacin, you're not really addressing the main issue. What is really causing the spasm? And again, it is the blood clots. So we need to deal with that. All right. Now, again, we have to review with the reason or the importance about having the complete bladder irrigation, because if you're not going to know, if you don't have a knowledge base about the CBI and how to perform this kind of procedure, then you're not going to be able to make your troubleshooting, right? So if you didn't know that the blood clots can cause the spasms after the prostatectomy, then you're not going to miss the troubleshooting, which is actually increasing the rate or also probably manually irrigating the system. Now, please don't forget the use of the elimination process. You have to look for those erroneous answers first. All those options that treat the symptoms ahead of time before even solving the underlying cause. Because this is really our first step here, initial action, to find out what caused the spasm. It requires us to do an assessment. It did not require us to deal with the pain, okay? Because the main problem here, again, is the blood clot, right? Now, another clue for you here is choose for those answers that can maintain the patient's safety, that can address the most immediate issue, which is basically the spasm caused by the blood clots. So make sure that you are going to retain those kind of reasonings. Now let's go for the next question here, number 2. A nurse is collecting a medical history from a patient being evaluated for benign prostatic hyperplasia. Which of the following symptoms should the nurse recognize as indicative of BPH? Select all that apply. Again, the situation says a nurse is collecting a medical history from a patient being evaluated for BPH. Which of the following symptoms should the nurse recognize as indicative of BPH? Select all that apply. Is it back pain? Is it B, frequent urinary tract infections? Or is it C, weight loss? Or D, blood in the urine? Or E, urinary incontinence? Okay, please don't forget the instruction here is select all that apply. And guys, just to give you some idea about the select all that apply, in this kind of test question, if you're gonna select a wrong option, that will be deducted to your the total number of your points. Okay, so right minus wrong, which I really don't like. But yeah, some of the other test items it will not deduct from your correct answers, but with this kind of format it will deduct. So you got to be careful in choosing your answers. Okay, I really want you to use that technique that I've been teaching you. Answer by elimination and answer by choosing those options that can really pinpoint the main issue. All right, not just a secondary or third option. Okay, so what are those assessment findings or symptoms? Is it back pain? Is it frequent urinary tract infections? Is it C, weight loss? Is it D, blood in the urine? Or E, urinary incontinence? So let's go through each option here. What about back pain? Letter A. Well, the back pain is going to be more associated with advanced prostate cancer that has metastasized. We did not talk about this earlier. Eliminate that. What about letter B? Frequent urinary tract infections. Well, the BPH can actually cause urinary tract urine retention rather, which can also predispose them to developing UTIs. Yes, that's one of our correct answers. Again, because of the obstructive flow, the urine will stagnate in the bladder and potentially can go back up. There is an ascending infection. And then what about weight loss? Is weight loss specific to the BPH? We'll find out. Well, weight loss is associated with prostate cancer, but not BPH. We're gonna X that one. What about letter D? Blood in the urine. Did we talk about hematuria? Yes, hematuria is common in the blood, the benign prostatic hypertrophy because of the enlargement of the prostate. That can also cause pressure on the urinary structure. So hematuria is common. We are going to select letter D as well. And let's take a look at letter E, urinary incontinence. Well, I've said something about the overflow incontinence earlier as well as one of the common features of the BPH because of the incomplete bladder emptying. So the patient will have this overflow incontinence. They're going to end up with wearing those incontinence pads. So we are left with letter B, letter D, and letter E. So our wrong options here are A and C. Now going for the strategies, what are those strategies that you're going to use here? Well, you're going to need to link those symptoms to the conditions that we were talking about, the BPH. And also we have to eliminate the options that are commonly associated with the other conditions. Some things that not going to jive with the BPH, remove them right away. Okay, and then we're going to have to focus also on the common complications of the BPH, such as the urinary retention, which can lead to UTIs, and also the others right here, the blood in the urine and the urinary incontinence. All right, moving into the next test question. A nurse is treating a patient newly diagnosed with benign prostatic hyperplasia. And which medication should you expect to be prescribed? So, new diagnosis of BPH. So, it's asking for the medication that could be potentially prescribed for this patient as a first line. Okay, is it the oxybutynin, or is it diphenhydramine, or C, ipratropium, or D, tamsulosin? Take your pick. All right, I hope that you had chosen your option. So let's go through the options here. Letter A, what is oxybutynin? Remember, this is one of the anticholinergic drugs that I said earlier, and this is used to treat what? Overactive bladder. Again, this is an anticholinergic. Just one of the modalities in the treatment of the overactive bladder, but it's not the primary classification that is used to cause relaxation of the prostate muscle. Okay, eliminate that one. So this is a drug basically that can cause what? Remember about the mnemonic that we just created? The D, which is basically the dry mouth. Remember? What else? What was that C? Do you remember what was that C? And then U and the B. All right. Dry mouth. There's also urinary retention. And what else? Okay. All right. So I need you to recall those. I'm not going to give you the answers right now. Now let's go into the next option here. Diphenhydramine. What is the diphenhydramine? This is an antihistamine that is going to be used for some other reasons. Let's say itching or for any allergic reactions. And diphenhydramine has that effect to cause urinary retention. It is not suitable for this patient with a BPH. Urinary retention is something that we don't want for these patients because the more it can complicate things. So diphenhydramine, we have anticholinergic. These are the names that we need to avoid for this patient. Now, letter C, what is ipratropium? Ipratropium is another medication that we can administer to a patient with a chronic obstructive pulmonary disease. Also, this has an anticholinergic effect. Okay, so this is something that we need to remove because it has an anticholinergic effect. It can also cause retention. What about letter D? We don't have any other choice but tamsulosin. So this is the one that I called Flomax. It can cause relaxation of the prostate muscle. Okay, so this can allow the urine to flow freely from the bladder into the urethra. And again, don't forget about the classification. What was the classification of this drug? This is the alpha blocker, which is basically an antihypertensive medication. And remember what side effect you can think of for the alpha blocker? It can cause orthostatic hypotension. Remember that side effect. Orthostatic hypotension. Especially for these newly diagnosed patients with a new prescription, this can really cause their blood pressure to drop. Okay. So, do you recall now the D cup, the dry mouth, the constipation, the what? Urinary retention, and the B, what was the B? All right, I'll let you answer that. Okay, so let's move on to the next question. A nurse is preparing a patient for post-op care following a transurethral resection of the prostate, which is the TURP. What should the nurse include in the teaching? Again, a nurse is preparing for a patient for post-op care following transurethral resection of the prostate. What should the nurse include in the teaching? Is it A, you might feel a continuous urge to urinate despite having a catheter? Is it B, you will stay in bed for the first 2 days post-surgery? Or is it C, you will need to limit your fluid intake after surgery? Or D, your urine should be clear yellow by the evening after surgery? All right, if you're paying attention to the lecture, you're going to get this correctly. So what is your option? Is it letter A? So let's go through the options. When you're going to select letter A, you might feel a continuous urge to urinate despite having a catheter. Well, because of the presence of the catheter balloon being inflated inside the urinary bladder, this can also create some amount of pressure inside the bladder, and this can cause the patient to have that constant sensation, the need to void. Okay, so this is an expected finding, possibly a correct answer. But we're not done yet. Let's take a look in letter B. You will stay in bed for the first 2 days post-surgery. Did we talk about keeping the patient in bed? No. We are going to encourage the patient to early ambulate. We're going to encourage them to prevent the complications such as the DVT. We don't want DVT in this post-op patient. All right? DVT, deep vein thrombosis. We don't want that. We always promote early ambulation to prevent this kind of complication. We're going to eliminate that. That is not a realistic nursing plan. You're not going to do that to your patient. Letter C, you will need to limit your fluid intake after surgery. Did we talk about limiting the patient's fluid intake after the TURP? Of course not. We are actually going to encourage to intake or to take in more water, at least 2,500, 3,000, right? And this is to prevent urinary tract infections and also to ease the urination. So no limitation. X this out. What about letter D? Your urine should be clear yellow by the evening after the surgery. Is that realistic? Did we say something that the urine flow will be clear already? No. No. Even during the first 24 hours or 48 hours, there will still be some pinkness in the coloration of the urine. And so this is not a realistic plan or statement. This is false reassurance. That is incorrect. So we are eliminating that right away. So we only have one correct answer, which is one answer, which is basically letter A. All right. That presence of balloon inside can cause this urge to urinate. Now, again, our strategy here is to recall for the post-operative guidelines that we had learned. We want to make sure that we are familiar, review the knowledge that we have gained from the past about the post-op care of this patient, especially with TURP. And we need to avoid those complications as well. We have to do those nursing interventions that can prevent the complications from happening, okay? Such as bleeding or irritation. And we have to also encourage or promote teaching of our patients about, or let's say recalling about those possible side effects, okay? Those medications that could possibly aggravate the complications. Okay, it's not really being asked here, but could potentially be associated. All right, so that is the end of our lecture today. I really thank you for your time attending the daily lectures and session. So please leave a comment at the bottom or in the chat box, but I would really like you to comment down below so we can see if you have any clarifications or any questions that you want us to answer in the next session. Please do that. I highly encourage that you do that so we will know if you're learning or if you have anything that you want us to discuss, please do so. All right, so I'll see you again tomorrow, and I'll be talking on topics about the urethritis and also the cystitis and prostatitis, and we're going to do some more of the Q&A as well. So thank you for your time. I hope to see you tomorrow, and you have a great day. Thank you.